project manager. I'd like to acknowledge that the Canadian Association of Schools of Nursing National Office is located on the traditional unceded territory of the Algonquin people. This is the second webinar of a series that are part of a project on opioid use and opioid use disorder that is funded by Health Canada. Today, you will hear a bit about the project and the recently launched e-resource, which is open access and available to you. We were also pleased to welcome several guest speakers who will provide you with a look at the equity-oriented approaches of harm reduction, trauma and violence-informed care, and cultural safety. We hope that throughout this next hour and a half, you will discover a new resource that will be helpful to you in your practice or education setting and provide you with an opportunity to learn from subject matter experts. At the end of the speakers' presentations, we will have time for a Q&A, so please put your questions in the Q&A box. Our first speaker is Carol Carpot, who is the Executive Director of the Canadian Association for Social Work Education. Carol will provide you with an overview of the project. Please go ahead, Carol.
Thanks, Leah. Hi, everyone. Bonjour. So I'll provide with a quick overview. In 2018, the Association of Faculties of Pharmacy of Canada, the Canadian Association for Social Work Education, Association canadienne pour la formation en travail social, and the Canadian Association of Schools of Nursing started this project with funding support from Health Canada. Our organizations are committed to working together to collaboratively foster curricular change in education programs for registered nurses, pharmacists, and social workers across Canada. The goal of this project is to ensure that health and social service providers enter the workforce well equipped with relevant evidence-informed knowledge to address issues related to opioid use and opioid use disorder. This is across the prevention, health promotion, harm reduction, treatment, and recovery continuums at primary, secondary, and tertiary care levels. To achieve this goal, the project has developed a series of outputs. The first was into professional education guidelines related to opioid use and opioid use disorder. The goal of the guidelines is to promote and guide curricular change in schools, faculties of nursing, pharmacy, and social work. Those education guidelines were completed in early 2020 and are now available online. The second output was to develop protocols that address selected areas within the education guidelines that will facilitate integration into member schools. To date, a protocol on stigma and naloxone are available. The third, more extensive, is an electronic resource for faculty and students in entry-level nursing, pharmacy, and social work programs. The e-resource provided our programs with information, teaching and learning materials, and tools related to the education guidelines. It provides greater and more in-depth content to foster the integration of the interprofessional guidelines into the curricula of member schools. It even includes a section on lived experiences, which I find to be great. Currently, the guidelines are also available in French, with the French e-resource and protocols being launched very soon at the end of the month, I believe. The e-resource, which was linked for you in the webinar welcome email, includes a wealth of knowledge developed by numerous experts in opioid use and opioid use disorder across, again, pharmacy, nursing, and social work. The unique interprofessional aspect of this project and this resource make it usable across a wide spectrum of health and social service providers. I hope this webinar, which will include a presentation of the content development, as well as some guest speakers on key topics within the area of opioid use, you will spend some time also looking through the resource, considering what and how you can use it in your courses. And we hope it will provide, we hope you will be provided you will be able to provide with some feedback in a short survey that we'll be sending following the webinar today. So to wrap up, I want to thank Health Canada for their funding, of course, Leah Watts, Cynthia Baker, and the rest of the CASN management team for their leadership and commitment. He has been doing an amazing job putting everything together with this project. So if you have any further questions, please don't hesitate to email Leah. So it's LWATT Watts, Leah Watts at casn.ca. Thank you, everyone. Enjoy the webinar. Merci. À bientôt.
Thank you, Carol. Our next speaker is Dr. Michael Beasley. Dr. Beasley was the co-lead with Dr. Feng Chang on the content development for the e-resource. Dr. Beasley is an associate professor at the School of Pharmacy at the University of Waterloo. His clinical and education research is focused on the role of health professionals in reducing harms associated with problematic substance use. Dr. Beasley will provide you with an overview of the content development process. Please go ahead.
Great, thanks so much, Leah. Can you see the slides and everything? Excellent. Yeah, so as Carol mentioned, this project was spearheaded by these great organizations that brought together so many great people on the advisory committee that identified, what kind of content would go into something like this. And we were fortunate to be able to put together a team that took the topics and learning objectives identified by the advisory committee and to create them with some help from some fantastic folks at the Center for Learning or Extended Learning at the University of Waterloo. So I'll give you a brief overview of who we were, who created the content, how we went about it, what it is, how it looks like, and talk about some things like language, the level of breadth and depth of the modules, and maybe even how to use them in your course. So my colleague Feng Chang and I were put together a submission to the project and tried to put together an excellent team at the University of Waterloo as well as at York University. So Feng and I are both pharmacy professors. Colleen McMillan is a professor at Renison University College School of Social Work, and Professor Shelley Walkerly teaches nursing in the Faculty of Health at York University. We were supported by Ahuda Shah, who took on the role of project coordinator, and we had Rosemary Colleen as well at the School of Pharmacy, who's got a lot of experience in continuing education and online education. And so many folks at the Center for Extended Learning at the University of Waterloo, who really not only took what we created and made it look nice and put it online, but also guided us through the process to make sure what we were doing was going to end up looking like a good finished product at the end. Excuse me. So 8 broad learning objectives and 65 topics were identified by the advisory committee. And so we divided these into sort of primary content creators and second readers, sought external expertise to fill in gaps as necessary, and then participated in our own review process within the team, and also the advisory committee, the management committee, and CASN also brought together lots of external stakeholders to provide feedback to us. Just to give you a brief overview of what's covered, there's 8 modules. Each module has about 6 to 12 topics within it for a total of 65. We cover the epidemiology of opioid use, what it is, what are the numbers, what's the impact, the continuum of care and available resources, screening, assessment, intervention, and follow-up, developing trusting, compassionate, and therapeutic relationships. We have a module devoted to trauma, violence, and cultural safety, one about opioid use education, and that goes beyond educating a patient to educating family support persons, educating the community, as well as decision makers. And a module about pain management and one specific to harm reduction. So what happens if you go onto the site and start to go through this content? So I'll just use an example, a few screenshots from, this is module 1, so the epidemiology of opioid use, and topic G, which is to differentiate between the type and routes of administration of opioids being used clinically and recreationally in Canada. Each module will start off with a series of learning objectives. For this one, we want to define what an opioid is, how opioids are regulated, what opioids are regulated in Canada, what opioids are present in the unregulated or illegal market in Canada, what types of dosage forms are there, patches, powders, pills, injectables, and how you administer them to the body, and some of the impact of unregulated fentanyls. Following the learning objectives, each topic will have a sort of summary that will go through the key concepts that will be covered in the module. And then this is an example of a section of what unregulated opioids have been detected in North America, including mostly the fentanyl and the fentanyl analogs, but also a few others. At the end of each module, there's a series of 3 to 5 questions, mostly multiple choice, but there's reflection, written questions, matching questions, other types of questions as well. And so, for example, at the end of this module, we talk a little bit about morphine equivalents. And so there's a question about figuring out a morphine equivalent for hydromorphone. And we talk about which opioids are prescribed most commonly in Canada. And so there's a question about that as well. One of the challenges in the area of substance use generally is the careful use of an accurate use of language. So endeavor to use non-stigmatizing language wherever possible. A second challenge in an interprofessional opioid and opioid use disorder project is to balance different terminology that's used across different professions. So we don't have the exact terminology across pharmacy, nursing, and social work all of the time. And so we've used multiple terms, but we've included a glossary and some examples right off the bat for the learner to take a look at and understand why you're seeing different terms in different places. One example is the people we're talking about, the person using an opioid, which in pharmacy is almost universally called a patient, and in other professions may be called the client or a person you're working with. And so we've addressed that right off the bat as well. So the target audience for this content are undergraduate learners in the areas of social work, nursing, and pharmacy. So as you can imagine, across that group of people, there are going to be learners with very different backgrounds. Someone could have a lot of humanities background in their courseworks, and the other person could have a lot of organic chemistry background in their coursework. So right off the bat, it's a challenge to make the modules accessible to all of these learners, but impactful at the same time. In addition, this isn't a standalone course that we're telling people to insert into year 2, term 3, or of their program. It's an educational resource that may be used in the first term of the first class of a program, or in an upper year senior level pain management course. So again, there we've tried to balance the amount of information, not to make it accessible, but also to make it impactful. Most modules are about 1,000 to 2,000 words, written words, that are formatted in a sort of easy to follow visual format, and designed to be accessible to not only all 3 types of students, but across their programs. I suppose it's possible that some students might be assigned all 65 modules to take sequentially. We felt that that was unlikely to fit that much stuff into a course. And also, as you saw when I went through the different learning objectives, we cover a wide variety of content. So we anticipated that many educators would assign modules a la carte. Thus, you may see content reproduced in different topics, because we felt that if it's important to talk about cultural safety, obviously in the cultural safety learning objective, it's also important to talk about that in the context of developing a relationship with a patient or a client. And so just as an example, I just taught a first-year pharmacy introduction to pharmacology course, where we talk about how drugs are used. And at the end of the course, I wanted to give the students a sort of small introduction to opioids and opioid use. So I chose 12 topics to assign to the students to review independently, about 5 topics for module 1, what are opioids, what's the rate of use in Canada, that type of thing. Topic A in module 4 talks about implicit bias, and I wanted to introduce that idea to the students in first year. And then module 7 and 8 talk about pain management and harm reduction. And so I chose some topics there. So that's just an example of how I went about assigning some of these topics to my students in the first year course. So I'm happy to answer any questions you might have now, and I'll also be around monitoring questions and in the chat and the Q&A. Thanks so much.
Thank you, Mike, and thank you so much to your team for all the work you did in developing this e-resource. So now we're on to our guest speakers. Our first speaker is Dr. Jane Buxton, who will speak on harm reduction. Jane Buxton is a public health physician and professor in the UBC School of Population and Public Health. She is the medical lead for harm reduction at the BC Centre for Disease Control, where in 2011, she developed the Intersectoral Drug Overdose and Alert Partnership, DOPE, which includes representatives from enforcement, ambulance, toxicologists, drug checking, coroner's office, health regions, and most importantly, people with lived and living experience. DOPE collaboratively identifies, discusses, and responds to emerging issues related to the toxic drug supply in BC. In 2012, she introduced an annual harm reduction client survey and led the BC take-home naloxone program implementation, which has shipped over 1 million kits to sites across the province and recorded over 100,000 overdose reversals. Jane uses quantitative and qualitative approaches in her research and is committed to partnering with the experts, people with lived and living experience, in developing policy, program planning, research, and education. Please go ahead, Jane.
Thank you so much, Leah. I'm hoping everybody can see my screen and hear me. What I will start off by saying is I have been working in the field of harm reduction for probably almost 20 years. And although I'm at the BC Centre for Disease Control, I should tell you that the opinions that I may give are my own and not necessarily representative. And I've really enjoyed hearing the background of how the course has developed, because I was actually involved in a similar course development for medical students. So it all overlaps. So I'd like to start with a land acknowledgement that I live, work and play on the unceded, ancestral and traditional territories of the Coast Salish people, namely the Musqueam, the Squamish and the Tsleil-Waututh nations. And I'm truly grateful to the caretakers of this beautiful land on which I am an uninvited guest. So what I'm going to talk about today really is harm reduction from a philosophical, it's a philosophy, it's an approach, and include some practical examples which will hopefully illustrate the messaging I'm trying to get across. One of the tenets of harm reduction is the inclusion of the voices of people with lived and living experience. And that's not just tokenistically, it's authentic inclusion. And I usually present with a peer. Obviously, we have limited time, and if you didn't attend last week, the last webinar, Gord Gardner spoke and has been able to give a peer perspectives, and there's quite a lot of peer perspectives within the course itself. So the overview is what harms are caused by illegal drug use, what is the goal of harm reduction, what is harm reduction, and what harm reduction services are available in Canada. I think we're well aware that there are toxic effects of illicit drugs themselves, substance use disorder and addiction. But I've outlined a number here, and often when I'm talking, I if we're face to face, I get people to throw out what they perceive as the harms. But what I'd like to say and explain here is that the harms that I've outlined are really due to the toxic, not just to the toxic effects of the drugs, but really due to the criminalization of substance use. So HIV and hepatitis C and bacterial infections, these are because people are using in unsterile situations. Criminal activities, people have to find the funds to be able to buy the substances, and also gangs, organized crime, who have no recourse to the justice system. So we see the violence occurring. Incarceration, we know that incarceration, we hear a lot about the US, but we can also see in Canada, it's disproportionate between different groups. People will overdose. There is unknown potency and constituents within the illicit supply. There's no quality assurance, and people may be using in a hurry because of the stigma and to avoid being found by enforcement. So many of the harms I would suggest that we could actually put under the heading of due to criminalization. I mentioned overdose, and I think last week, the last webinar addressed this, but just to give you a BC perspective, between 2000 and 2012, we used to see about 200 overdose deaths in an entire year. We are now, since COVID, seeing 160 overdose deaths per month. This is absolutely tragic. The rate is unacceptable, and all unintentional drug overdoses and deaths are preventable. And we know that the toxic supply is really what's driving this, but we also have to think about why people are using. And overdose death is preventable, and I think I can't say that enough, and it can affect everyone. When I showed you that previous, how much it's really increased, and if we compare it to COVID deaths, it's not surprising that people who have lost their loved ones, parents, family members, really feel left out and not listened to, because there's so much efforts being put to COVID, and quite rightly so, but what is happening to 7,000 people have died in BC since the overdose crisis was declared in 2016. So it's huge. And of course, people who die at an earlier age. The median age is actually 44, whereas in other causes of death, it's much older, in the 80s. So what's the goal of harm reduction? I think if we asked a number of people what their definition is, people would come up with different definitions. And I think really it's good to adapt one that suits you and that you can readily share with people when they say, what is harm reduction? Why do you believe in harm reduction? Harm reduction aims to keep people safe and minimize death, disease, and injury from a high-risk behavior, promotes safer practices. It really acknowledges that people will carry on with these risky activities. I ride my bicycle, but I wear a helmet, so that if I do come off, that I reduce the risks of the attached harms that are attached to an activity. It provides the tools and services for an individual, their family, and their community to be safer. We participate in many harm reduction practices in our day-to-day life. As I said, wearing a bicycle helmet, wearing a seatbelt. If you're working on the wards, or if you're working in the downtown east side, you would not wear open-toed sandals, for example, in case you to avoid injury. As far as pharmacies are concerned, we put labels on prescriptions to take with food, or warnings with regards to do not drive, this may make you drowsy. So I think it's important to understand that harm reduction that we're talking about today is around substance use, but harm reduction really is something that we participate in our day-to-day lives. As I said, it's a philosophy and a human rights approach. We often think of it as a public health approach. Everyone has the right to the best possible health, and it treats people as human beings. It asks people what they need to be safer and healthier, and how can we help you achieve your goals. It doesn't insist on abstinence, and I often give the example that we don't refuse to treat somebody who has pneumonia until they stop smoking. We don't refuse to treat somebody who has develops diabetes until they lose weight. We meet them where they are and try and help reduce the risks, and to help connect them to services and to develop relationships. We often hear in the media this, well, we should be doing more for treatment and prevention and enforcement and not harm reduction. We all work together. It's not an either or. And again, it's really meeting people where they are in their substance use journey. And this really helps us to think about why people are using substances. People may use opioids, for example, to treat physical pain. It may be due to overprescribing in the past after an acute injury. And I think you heard the last webinar around opioid use and how OxyContin was removed from the market. It's also used to self-manage not just physical pain, but mental, emotional, and spiritual pain. And with events and with the news and with the colonization and the traumas that adverse childhood events and sexual abuse and poverty and homelessness, I think it really gets across that it's not just the individual using substances we have to think about. We have to think about the social determinants, and we also have to contribute not only from a health perspective, but also from the social issues. In healthcare, we have a habit, and I worked as a family physician, have a habit of telling people what they need to do, what they should do. This is how we are going to help you. But we have to avoid being paternalistic and telling people what's best for them and what they need. We have to practice client-centered care, reach out to a person, find out their needs at that time and how we can provide it for them. And they may not want to have help at the time we're talking to them, but we need to keep the door open. And whether we're a pharmacist, a social worker, or a nurse, it's developing those relationships that are so important. And really just to point out that people are using substances often to prevent withdrawal, to feel well and to function. And as I said before, it's a health issue, not a criminal one. And it's one that society as a whole needs to address. Over time, people who are using substances will need develop dependence, will need more and more substance to prevent withdrawal. And withdrawal symptoms are absolutely awful. The shaking, the sweating, the nausea, and not being able to function. And this tolerance can actually be lost very rapidly over a couple of weeks. So we also have to be wary that if somebody has been abstinent, been in prison, been into detox, that we have to make sure that they're aware of the risks. And stigma is huge, and people will hide their use. And we need to really address stigma, both from our people, family members, the public, and also in our own professions. So when we think about what people would like, again, we need to ask what it is that people need. one size doesn't fit all. It would be very different in the downtown east side in Vancouver to somebody who is in the north of BC, and different age groups, different gender, different sexual orientation, different substances used. And the experts are the people with lived and living experience, and we need to ask and we need to involve them in every step of the way when we're developing programs and policies. Engagement of people with lived and living experience, I'm very passionate about this. It's recognized as best practice, and my goodness, folks who use substances are so creative, can really come up with ideas, thinking out of the box, how we can do something. And when we look at what some of the things that have been implemented, such as overdose prevention services, people with lived experience, they just get on and do it. And then we meekly follow suit. So it's so important to actually ask what is needed, how we can help, and in what way. There was a mention about language, and we always think we treat people with the same respect, regardless of what walk of life they're from, what their issue is. But I think we don't always do that. And we must reflect and consider the language you use, and listen to the language that colleagues use as well about people who use drugs, and using that person first language. And just making sure that we're not, although people will use certain terms about themselves, that does not encourage us, should not encourage us to use it. And we hear about people experiencing barriers to accessing services who are usually told they're unmotivated or non-compliant. And as one of my colleagues, a peer advocate, always tells me, people who use substances aren't hard to reach. You make your services hard for us to access. So ask us what we need and where we need it. And I think the other thing that we often hear is around clean tests, being clean, being dirty. And being clean is not a way that we should, even when we're referring to somebody's urine test, we should not be using clean and dirty. And language really does matter. And this was a quote from one of some of the qualitative work, that a person was ingrained in her head that they were an addict, that they were dirty, selfish, and all of this shit. And then when she started using, changed the language, and she had a poster up beside where in her room, it changed how she viewed herself as a person. So it's not just how we should talk about people, it's how people can consider themselves, and it really does go beyond. So finally, what are the harm reduction services in Canada? I think everybody's aware of opioid agonist treatment and treatment alternatives to the toxic supply. I'll talk a bit about drug checking, harm reduction supplies, observed consumption, and take-home naloxone. So opioid agonist treatment, methadone has been around for a long time. Suboxone is now, certainly in BC, first-line treatment. Obviously, these are excellent treatments and do help people to reduce their use of illicit substances, and often will stop using from the illicit supply. Doesn't suit everyone, and we've had studies around injectable opioid agonist therapy, the Naomi and Salome study, and we've also, and that's continuing, to have hydromorphone, and then tablet injectable OAT, there's some work being done. In light of the dual public health emergencies, BC developed the risk mitigation guidance, and that allowed physicians to prescribe Dilaudid, Cadian, and then Meslon, and pharmacy were able to deliver, which was something that had been stopped in BC. And recently there's been a course developed by the BC Centre on Substance Use around nurse prescribing of OAT. So expanding access, making it easy. In public health, we always have a mantra, which is make the healthy choice the easy choice. Drug checking services, I think these are available to some, but not everyone. Currently, they're available at our supervised consumption sites and overdose prevention services. There is the Get Your Drugs Tested, and you can deliver in person and get it online, your result, or you can mail it in. There are test strips, and they're pretty sensitive at picking up fentanyl and fentanyl analogs, as long as it's diluted appropriately, or you can get false positive. But benzo strips, when you're actually testing substances, are not very accurate, because benzos aren't very soluble. And there's various technologies of the FTIR and other technologies which give us more information. But what we've found from these sources, as well as from coroner's data, as well as from the drug analysis service, is that with our opioids now in BC, at least 50% contain benzodiazepines, and of that 70% is atizolam. So it's huge what the substances are being contaminated with, and there's always new fentanyl analogs coming out. Harm reduction supplies, it's not just helping people to be safe, it's engaging people and helping people with other services. Needs to be some education too. And it's really important that we have safer smoking as well as safer injection supplies. We do a study here in BC, which was mentioned, and we now find that more people inhale opioids than they do inject. So it's so important to have foils and straws so that people can do so as safely as possible. And also to make sure that they can dispose of used supplies, whether it's needles or broken crack pipes, and we do provide needle disposal that people can carry with them. We also need to make sure that there are facilities within the community where people can easily dispose of used needles. And we have, obviously, pharmacies are another site that can collect in used equipment that people have that may be contaminated. Observed consumption, I think everybody has heard of Insight, but may not realize that this was not the first supervised consumption site. The first site was in Dr. Peter Center. People were being treated there for HIV. It was their home, and yet they were having to leave and inject in the back alley. So it was determined, and on discussion with Nurses College, that it was more appropriate for them to be observed, and obviously an ethical duty to help people to be as safe. So Dr. Peter Center actually introduced supervised consumption site in 2002, and then Insight opened in 2003. In 2016, we were seeing huge numbers of overdose deaths in BC, and our our Minister of Health introduced overdose prevention services and said, it's taking too long to get permission through Health Canada, through Section 56 exemptions. We're going to open up overdose prevention services across the province. And these are often manned by people with lived experience, again, making that connection with folks. Another thing that we have recently introduced is the episodic overdose prevention services. And the idea here is if somebody is in your health unit or is in the hospital, is that you will agree to supervise. Now, this is optional, but it really, again, we know people on just being told you can't use, people will use in a very dangerous way, lock themselves in a bathroom, leave against medical advice. So these are some new things that have been brought in, which I think is really excellent, and we're gradually seeing an uptake. And of course, peer witnessing. So you'll have somebody in a single room occupancy hotel who'll phone their friend and say, hey, I'm just about to use, can you pop in and just be with me? The pictures here are really showing those different sorts of the more clinical supervised consumption site, an overdose prevention site, which was it's sort of in a trailer, and then a more comfortable, relaxed site in a situation where it's in supportive housing. And of course, the peers that are witnessing will have their take-home naloxone. Naloxone, and I don't need to tell you folks, has a greater affinity for the mu receptors, pushes off the opioids, and will reverse an overdose and restore the breathing. We started in BC because I had people with lived experience saying, why on earth don't we have it? So we introduced it in 2012. Initially, it was treatment only. BC College of Nurses said, okay, we want to be able to distribute, let's put it in scope. And now it's unscheduled and available at numerous community pharmacies. So in BC, we've got it in over 750 community pharmacies. We developed an online training module so people can arrive with a certificate to the pharmacy and say, I've done the training. We have shipped over 1 million kits, and we've had over 100,000 kits reported as used to reverse an overdose, but we know it's far more than that. All our emergency departments offer take-home naloxone, and many hospitals and acute care wards do as well. When we got to our millionth kit that we shipped, we asked people with lived experience to tell us what it meant to them. And the main message was, naloxone's great, it's saving thousands of lives, but it's not enough. So my key messages: client-centered care. We need a variety of options to meet people where they are on their journey. We must engage with the experts in all that we do. Opioid agonist therapy, OPS, SES, and naloxone saves lives. It's not enough. We need to expand observed consumption, and that includes inhalation because more people are smoking than injecting. And we need to provide treatment alternatives to the toxic drug supply and the discussions around decriminalization and safer supply. So thank you, and I'll stop there, and we're saving questions for the end, so I will hand it back to Leah.
Great, thank you, Jane. And yes, we will circle back to questions after our next couple of speakers. So our next speaker is Dr. Nancy Poole. Nancy is the director of the Center of Excellence for Women's Health, an NGO research and knowledge exchange center hosted by BC Women's Hospital and Health Center in Vancouver. In that role, she leads knowledge translation, network development, and research related to improving policy and service provision on gender and women's health. Nancy has co-led system change initiatives and co-developed toolkits, training curricula, and guidelines on trauma-informed practice with agencies and governments across Canada. Dedicated to connecting across distance, cultures, and sectors, Nancy is a catalyst for bringing knowledge to practice and policy to make social change. Please go ahead, Nancy.
Thanks very much. So can you see my presentation now?
Yeah. Great.
Do I need to make it the full screen? Does that make a difference? Maybe. So thanks very much. It's great to be here and to hear the great presentation by Jane, and looking forward to Vicky's as well. In the course that Mike introduced and Leah, there is this image in Module 5 on what's equity-oriented healthcare. And I think this is really a lot about what we're all about today, is thinking about how all of the nurses, pharmacists, and social workers can multitask in this way of thinking about how to bring cultural safety, harm reduction, and trauma and violence informed approaches together as you do this work. So I've been asked to talk a little bit about the trauma-informed side of it, about what trauma is and how it links to opioid use, and what is said in the course about trauma and violence-informed approaches. So, you know, trauma is really about experiences that overwhelm a person's capacity to cope, and it comes from so many directions. It can be early life experiences, later life experiences, and can also really be linked to poverty and having life-threatening illnesses, and intergenerational events, grief and loss. So it's a very, wide range of things which can mean that a person is overwhelmed. And I'll talk a bit more about that as we go along. But I think it's interesting in the case of opioids about how chronic pain and trauma go together. And Jane alluded to it, that people use opioids for both chronic pain and for relieving mental health concerns, and can be more at those who've experienced things like sexual abuse can be more at risk for developing certain kinds of chronic pain and more vulnerable to opioid use. And substance use, depression, and anxiety are also very common responses to experiences of trauma and violence. And so it all becomes really closely linked. And I think it's important to just think about some subtleties within the links between trauma and opioid use. And, compared to other types of substance use, women and men addicted to prescription opioids are more likely to report a trauma event and tend to have first experienced trauma at a younger age and are more likely to report a childhood trauma. And people who have 5 or more of those adverse childhood experiences are 3 times more likely to misuse prescription pain medication and 5 times more likely to inject drugs. So lots of things to think about as we're looking at the connection between substance use and opioid use and trauma. And really important also, Jane's organization and the First Nations Health Authority have really looked also at how intergenerational trauma is linked for Indigenous people. And I know that Vicki will spend a bit more time talking about it, but it's interesting that among men and women who are not Indigenous, men are much more likely to overdose as opposed to women, but that is not as true in the First Nations population. And I think, that shows that intersecting of more than one thing, like colonization and residential school experience, as well as gender being influences on substance use. So at the center, we often try and bring that fourth thing in, which is bringing in how sex and gender also are in play, as well as we are trying to think about harm reduction, cultural safety, and trauma-informed work. And certainly worked with Leah and others in the context of this course to also bring sex and gender-based analysis in. So as we do this work, I think it's super important that we think about how to bring these principles of trauma and violence informed approaches in. And I'm going to talk really quickly about each of these. And if you want to find more, I know that the course refers to this booklet that the center has created about trauma-informed practice and the opioid crisis. So I'll just talk briefly about being trauma-informed as we work with people on opioid issues. And I think for social workers and nurses and pharmacists, the first part is the most important, this part about being trauma aware, understanding how common trauma is, and that many people who come to the healthcare system will have trauma histories, and that we can act in a way that takes that into account without forcing disclosure in the context of our work. And we need to really recognize how individuals who've experienced trauma may have more difficulty engaging with services. So really that we need to be able to understand how rage and treatment refusal, mistrust and fear may be linked to trauma, rather than seeing this as some kind of problematic behavior. And so, you know, without trauma awareness, there's the possibility that practitioners will misinterpret people's behavior and act in ways that increase those feelings of fear and loss of control, which may cause disengagement from the help that is so richly deserved. So another part of awareness is really thinking about these long-term effects of trauma and how it affects each and every dimension of wellness: physical, cognitive, spiritual. Jane mentioned that as well, behavioral, emotional areas. And I think that's why we have taken so long to come to understand trauma-informed approaches, is because they do touch on so many different areas of life and overlap with many other health conditions. And I think it's really interesting in the modules, you'll see a piece about this coping skills, this vision of wellness as being in all these areas as well. And I think that, you know, really speaks to how the course pulls together both the issues and the approaches. The other part of it, I guess, is recognizing in the moment trauma responses in the work. And this can, I'm not going to spend a lot of time on this today, but, you know, as well as those bigger long-term effects, people may, in the course of our interactions with them, experience an in the moment trauma response that we also need to be able to know how to support them to recenter and to understand. So trauma-informed approaches are really a lot about a way of working that recognizes, you know, the prevalence and impact of trauma on those who are coming for services, and is really, you know, designed to be as a system, organization and service to avoid re-traumatizing individuals and supporting safety and choice and control. And you can see how that could be reparative of lifelong experiences of feeling power over and overwhelmed. So really, really interesting basic approaches we can do around creating safety, really building trustworthy relationships. And it's very much a relational practice. And thinking about how we create physical, emotional, and cultural safety through the environment of the service and the way we interact. And clearly, you know, offering options is super important. Being clear and respectful, and offering opportunity to ask questions and to present opinions and ideas about that, as Jane mentioned, the creativity around what might work for that person, and giving people time and respecting the decisions, focusing on strengths, being collaborative, offering information about a whole range of options. And again, as I mentioned before, noticing those in the moment trauma responses and really stopping the discussion and offering options for self-calming. It could be something simply like having a drink of water, and really helping them think about what triggered it, and is this something they've noticed before, and really helping them not feel like they're out of control or they're going crazy or whatever, but normalizing it and supporting people to figure out what might work for them. So Lots to think about in being trauma informed, some very simple practical things and really bigger ideas as well. And this page around building resilience is right out of the course about, you know, how we can acknowledge resilience, promote skills, encourage grounding, facilitate development of the pain management skills as well through a whole range of alternative ways as well, and really promote and teach relational skills and create safety plans and facilitate goal setting. And I think another big part of it from the violence and trauma-informed approach is really recognizing that it is important for people to have connections to trauma-informed, harm-reducing, culturally safe community supports, and that community resilience is just as important as we do this work as building individual resilience. And these things like employment and income support and housing and social support programming really influence a person's ability to cope and thrive in their environment beyond the interaction they'll have with the social worker, nurse, or pharmacist. So that's my quickest version of trauma-informed practice, and I'm happy to answer more questions later or have people connect with us at the center. Thanks so much.
Thank you, Nancy. Our final speaker is Dr. Victoria Smai. Dr. Smai is faculty and the director of the Arthur Labatt Family School of Nursing, Faculty of Health Sciences at Western University. Victoria began her academic career as a faculty at the University of Victoria in 2001 after almost 25 years in clinical practice. Prior to her current position at Western, she was faculty and director of nursing programs at Ontario Tech University and faculty and associate director undergraduate programs in the School of Nursing at the University of British Columbia. Victoria's program of research is focused on addressing health inequity with particular relevance to policy and practice in the areas of Indigenous health and gender-based violence. Through her research, Victoria has contributed to anti-stigma, racism, and health equity work in Canada and internationally, and the uptake of equity-oriented approaches that include the concepts of cultural safety, trauma and violence-informed care, and harm reduction. Over the past 2 decades, Victoria has worked closely with several national, provincial, and local mental health organizations as a board member and has been a consultant to organizations such as the Mental Health Commission of Canada and the Native Mental Health Association of Canada, now called the First Peoples Wellness Circle. In addition, she has been involved in a full range of committee and board activities across Canada to contribute to the shaping of nursing education provincially and nationally. And I will turn it over to Victoria now.
Thanks so much. Leah. I'm just going to pull up my presentation here. All right. Where did you go? Sorry, everybody. Oops, it's not coming up. And there it is. Can't seem to. Oh. Can you see my screen?
I can.
Oh, you can see it? Okay.
Yeah.
Thanks. Sorry, I was just. There you go. So it's just a real pleasure to be here and to be here with Nancy and Jane after all these years. So this is wonderful. And so I'm really thrilled to be here. Thank you for your introduction, Leah. And I just want to say, I also am a white settler originally from Hamilton, Ontario, which is the traditional territory of the Haudenosaunee and Anishinaabe peoples. And so it's just absolutely great to share with you this work. I'm speaking basically on behalf of the Equip Healthcare team, because that's the work that I've been doing over the last decade with this group, and the work that I'm presenting on cultural safety really does come out of that research. From that perspective, from the Equip perspective, and this is our take on the key dimensions of equity-oriented healthcare, which thank you so much, Nancy, which you shared. We speak about these three key dimensions: trauma and violence-informed care, harm reduction, and culturally safe care. And these are the 10 strategies to guide organizations in enhancing their capacity for equity-oriented services. So I'm not going to go into them, but they make perfect sense given what Jane and Nancy have already been speaking about. So, and I'll talk a little bit more about these as I move forward. So first of all, I think it's really important to visit the notion of culture, because in this context, cultural safety, of course, has this big word culture right in the middle of it. And our take and the work we've been doing thinks about culture as a relational concept, real dynamic, it's ever changing. And many tend to think of culture in terms of ethnic groupings, such as Chinese, Mexican, or First Nations, often referred to as ethnocultural groups. But cultural groups instead might be divided into different types of social groups, for example, by age, sexual orientation, gender identity, language, or by particular professions such as teaching, medicine, nursing, law, or by athletic groups, just to name several. So we can all think about the number of cultural identities that each of us has in this moment in time. So given this multiplicity of cultural identity, my favorite definition of culture is actually from Stuart Hall, where he talked about experience lived, experience interpreted, and experience defined. So let's just think about that when we're thinking about cultural safety then. In cultural safety came from Māori, which is the Indigenous group in New Zealand, and in particular, actually, Māori nursing. And it's a highly relational concept in keeping with how we're thinking about culture as well, because it is considered as an approach to practice based on understanding the impacts of inequitable power relations, racism, discrimination, and historical and current health and healthcare inequities. So that's one piece. And it is an anti-racist, it's a deliberate anti-racist, anti-oppression, and anti-discriminatory stance. I think this is really important to understand because it comes from a critical perspective. And it also, I think, works very closely alongside what you mentioned, Nancy, which I love, is this notion of cultural humility as well. These two concepts go hand in glove. That is our humility in working with another person, in working with other systems, and in trying to understand where somebody else has come from and those multiple cultural identities that any given person might have. The other part of cultural safety that is crucial is to understand that cultural safety is only, a situation is only cultural safe as per the person who's receiving the service. So although we work to address these organizational changes, etc., in working with individuals, we have to keep this really important idea in mind. So there's several other pieces of cultural safety that we need to think about. So it shifts attention away from cultural differences as a source of a problem to the culture of healthcare as the site where we can actually take action to make our environment safe for all people. It also moves beyond cultural sensitivity, which is important, but to place responsibility actually on healthcare providers to create culturally safe environments. That is, the onus is on us. And it foregrounds social justice goals as essential to healthcare with the aim of shaping healthcare policies and practices. and the organizations. For example, we might want to think about intake forms, visiting policies, and even the physical layout of an organization can make people feel more or less welcome. So for example, think about entering a clinic with bars in front of the reception staff versus a low desk with plants with a friendly face saying hello. And it also takes into account the inherent power imbalances between you as the healthcare or social service provider and the person who's coming to your care. So the why. So why cultural safety? Well, I think most of us here probably know because of long-standing colonialism and neo-colonialism. So indeed, the development of an anti-racist and anti-oppression stance is actually key to recognizing and addressing the experiences, the inequities experienced by Black, Indigenous, and other persons of color. Inequities that are supported by institutional structures and systems underpinned by white normativity. In her discussion of the unique features of Indigenous health equity called IND equity, I-N-D equity, Bernice Downey, an Indigenous nursing scholar and anthropologist, draws attention to the impact of colonialism and racism that has on the health and well-being of First Nations, Métis, and Inuit, and the need to address the social, political, and historical determinants of, for example, in the case of mental health, is what she's talking about, and the issue of structural violence. So the why is really very close to us right now. Recently disclosed racism and discrimination in Canada surrounding the horrific death of an Indigenous woman in a Quebec hospital, Ms. Joyce Echawan. The investigation into emergency department staff playing games to guess blood alcohol levels of Indigenous patients in British Columbia, and an over a decade-long investigation into the tragic death of an Indigenous man, that is Mr. Brian Sinclair, who had a urinary tract infection and waited for 34 hours without being seen in a Manitoba emergency department. This has brought renewed attention to the harms of Indigenous specific racism. And then, of course, more recently, the discovery and unearthing of Indigenous children from the residential school era. So when people ask the why do you worry about this? That is the big why. It's a big why. The harms of racism and discrimination are well known and well documented, and they have been well documented for many decades. So in terms then of racism, racialization, and intersectionality, just want to be sure that we're all kind of thinking about the same thing. So racism, of course, is a process of differentiation, completely linked to other social processes of differentiation, whereby social groups are identified, separated, and treated as inferior or superior. And then there's this very important concept that goes kind of hand in glove, which is racialization, which is the process of social differentiation based on, or even racial categorization, by which people are labeled based on physical characteristics or arbitrary ethnocultural or racial categories. And then intersectionality, over 3 decades ago, Kimberly Crenshaw coined this term to describe the complex intersection of these social categorizations that we have. Social categorizations, sexism, racism, ageism, homophobia, classism, all of those things that can be very oppressive and intersect with each other to operate together and exacerbate each other to create inequity. So that is the big why. And when we think about the opioid use, then we need to understand the unique features of discrimination that are associated with opioid use itself. So, and I think, Jane, you really outlined those very thoroughly, what those might be. And we need to think about where cultural safety fits in this. I think it fits extremely well because it's another process of social categorization that marginalizes people and where their treatment is impacted in a big way. So what can we do? We can create organizational shifts that I've talked about briefly with signage, physical layout, removal of barriers, physical barriers. I know COVID-19 has presented a few challenges in this regard. We're pretty smart people, we can figure it out. And those policies, guidelines, the things that are exclusionary. We can also respond to discrimination in the workplace. So consider yourself, consider the goals, whether you're going to stop or educate or both when you come up against discrimination. Consider your setting. So sometimes in your setting, you might feel more or less comfortable depending on whether you're in public as a speaker, for example, or whether or not you're at home with your family. These are different things, but require some kind of a response. The tone of your messaging, whether it's in anger or in a good way, people don't want to be lectured, but to keep that, the idea is to keep the conversation open, to keep the dialogue open with people and to address, and also to consider relationship. And again, this is about whether you're with family or strangers, etc. So I've got a few examples here, but I won't keep us because I know we need to get to the questions, but just a few examples. So, you know, in expressing your feelings. So I feel very uncomfortable with the way you're speaking about people who use drugs. I want to discuss the issue with the respect it deserves. These are some ideas for how we might language. Questioning the validity. So all people who use opioids, do you really think so? Point out policies or standards. What you just said could be considered discriminatory. I think you should stop. Paraphrasing or repeating back. So you're saying all people who use drugs are criminals? Challenge the stereotype. Sounds like you think da 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 da. Did you know that da 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 da? So these would be some of the information that was provided today so beautifully, Jane, for example, so people can really understand the issue. Disagree. I often use this one, and that is not at all my experience. And then go on and share some of my own experiences. Expressing empathy. It sounds like you've had a bad experience. Help the person self-reflect. How would it feel if someone made this kind of comment about your family member? And for a long time, I didn't realize that. So that is putting yourself forward in your own learning. And I would underline there that needs to be absolutely authentic engagement. So in terms of cultural safety, I would really draw your attention to the Equip Healthcare site, where there's a cultural safety modules, there's trauma and violence informed care modules and harm reduction, and to think about how the simple things you could do to make things better within your organization. Some of them, they don't cost anything. In fact, some of them are very cheap ways of intervening, and there's really a lot you can do. So without further ado, I'll go on, but thank you, merci, miigwech.
Thank you very much, Vicki. If anyone else has any questions, you can type them into the Q&A box now. There was one question from Carla to Jane. So the question was that the majority of consumption is through inhalation, yet having inhalation as part of a supervised consumption is often not there, and in Ontario is not part of the mandate. What are your suggestions to advocate for this essential service?
Well, from our perspective, I think what helped was having the data. We know from BC that the main mode of use before somebody dies is actually smoking rather than injecting. And then having the information that showed that more people were smoking opioids than they were injecting. Helped us to bring this forward with our Ministry of Health, who said, yes, we'll provide funding to help this happen. It's a challenge because in BC, we have, obviously, the weather is not necessarily as cruel and cold as it may be elsewhere. We have inhalation sites that are under a tent. We've worked with WorkSafe BC to make sure these are as safe as possible. We're now working with WorkSafe BC to look at how we can implement smoking areas within existing sites. Another challenge is to make an inhalation site and to have the proper ventilation and things is a really expensive way to go. So how can we adapt and have the smoke being exhausted outside the building, as well as protecting people who are working there? So it's a work in progress, but we did, by sharing the concerns with our Ministry of Health, actually they put forward funding back in October to enable each of the health authorities to introduce inhalation sites. So I'd be happy to share anything from our experience that may help move this forward, but I realize that I'm in a very privileged position being in BC and having support for harm reduction in general from our ministry.
Thank you, Jane. I don't see any other questions right now in the Q&A, but I had a question I would like to pose to our guest speakers. So the majority of attendees here today are faculty and some are students. And just thinking about as they are entering into various workplaces with cultures of their own, I'm wondering if you have any sort of tips or suggestions that you would have for faculty educating new graduates across the three professions and potentially others, and for students, how they can kind of integrate these concepts that were discussed today in their workplace if it's sort of going against the grain of the culture that's currently there. So any words of advice for educators of our new graduates or for students who are on the webinar today?
Well, I'm happy to talk as an educator, what we're kind of doing in education here, just briefly, and I'm very interested to hear what Jane and Nancy have to say about this. But, you know, the decolonizing work, which is, by the way, not for the faint of heart, because let's face it, this is a process that's going to take quite a lot of time and a very important work actually that we're doing alongside our Indigenous colleagues here who are leading the way in this work. And this is about looking at curriculum. This is about even how we choose texts, how we language things within our curriculum, and to make it, first of all, safe and comfortable for all people within the academic realm. And one of the things we've also done in nursing, which is everybody here, except for maybe a couple of people, it's about 98% of us, faculty and staff, have taken the ICS training. And we have ICS, the discussions about decolonizing approaches in all of our council meetings. So every council meeting has an anti-racism, anti-oppression forum. Over the next year, in particular, we've struck an anti-racism, anti-oppression working group or committee. It's actually a standing committee of the whole. Things like that that are just the practical things that you can do right away. Working together with our Indigenous colleagues, taking the lead, but also doing the work, because my Indigenous colleagues are busier than whatever, and they just ask us to do the work. Like, just do the work and don't wait, and do your own reading. You know, get into those books and find out what's going on, educate yourself, etc. So I'd say those are the first sort of easy things you can do alongside the things that I've talked about earlier in terms of our own, creating our own anti-discrimination kind of languaging.
You know, I've really found there is a lot of curiosity and interest in trauma and violence informed approaches. And sometimes I think that is a great thing, is to come through the trauma and violence informed door and in the course of that, make the links to cultural humility and anti-oppressive work and harm reduction, etc. It's so interesting about them all as relational practices, all as anti-oppressive practices, etc. So if you can find the door that the students or the workplace is are interested in, I think the others can come, almost like the coat hanger or the old-fashioned wire coat hangers. When you took one out of the closet, all the rest came in a bundle with them. And I guess I just feel like that's what we're learning now. And that's why I use that term multitask at the first, because I think that's something that nurses and others are very used to doing and women are used to doing. And so if you can think about it in those ways, oh yeah, we need to link in the harm reduction and the trauma-informed and the culturally safe together. I just think it can be really encouraging to people. And the other, connecting up piece I found really interesting is that for many years, we've been working on violence against women issues, et cetera, but we didn't get as much attention to violence against women until we started to talk about trauma-informed approaches and thought about how to bring the Indigenous wellness piece into it, how to bring the public health piece and the ACEs piece into it, and how to really welcome the biomedical people, the neurobiology people in. And that's why I think we're in such a great time for making all this happen, is because there is recognition and connection of all of those forms of wisdom, feminism, neurobiology, traditional wisdom, and cultural interests, harm reduction, are all, public health, are all really seeing the possibilities and actually doing the work together. So I think it's a great time.
Yeah, and from my perspective, I'm probably a bit more pragmatic. I think we see students who are, idealistic, think they can change the world, really understand this, and then they go to a workplace where perhaps the culture, however we want to define it, is not quite the same. I think we should show by example how things can be done. I always suggest that people look for somebody who's like-minded, because you can really feel if you're in a new environment and everybody is not supportive, for example, of harm reduction, you can really feel as though you're a silenced voice. So I think it's important to find allies wherever you are, and also champions, because that's what really gets a place moving. We have to understand that people have their ideology, and sometimes that ideology is just don't use drugs. And we have to come at it and get people to change their minds and their hearts. And I think it's our new students who are going to go and change the world, but we don't want them to get so frustrated that they kind of give up. And then my other piece of advice is, where possible, bring along somebody with lived and living experience. Their voices are so much more powerful than certainly mine is. It's that reality. So I think it's really taking the chances that you can. Don't back off from discussions, but don't force the issue, because you'll get people's back up. And think about your small triumphs as you go along. Don't expect to change everything, but just, when we look back, if I look back what's happened over the last 5 years, for example, it's huge what we have in place now, how we can discuss things, how this is just, standard. We talk about these things. We must talk about these things. Whereas before it was kind of a little bit on the side, and some people did. So I think we just need to support our young, our students that are coming out and help them keep their idealistic notions and help them along.
Thank you very much for that. And I'm just cognizant of the time, so I think it's time for us to wrap up. I just want to say a big thank you again to all of our speakers today. A lot of food for thought for a Monday, so lots to think about throughout the week and as we move forward. So thank you again to all of you. And I will be following up with a survey for attendees, so please consider taking a couple minutes and just completing it. We would really appreciate that. And we're also having our third webinar of the series on Friday. And this webinar will be looking at chronic pain. So please keep your eye out for the registration link if you're interested. And that's it for today's webinar. Thank you, everyone, and enjoy the week ahead.